palliative care and medicines opportunity to present during our FACE lectures on a monthly basis. And really great to have international speakers who are going to be part of this lecture today. Our lecture today is on the non-pharmacological symptom, self-management, the current evidence and current practices. It's great to introduce you to the GAP project, and the GAP project is all about symptom self-management. UCT is part of Workstream 3, which is part of a big global consortium looking at palliative care in low middle income countries. I've got the pleasure of introducing Dr. Lindsay Farrant, who is the PI at UCT for our GAP project. She is joined by Mr. Sonwabiso Ngcowa, who is a PhD student in our division with a background from anthropology, and also from King's College is Dr. Clare Ellis-Smith. Dr. Clare Ellis-Smith is a UCT graduate, but she is now currently working in the UK under King's College. Thank you very much, and please will you, this lecture will be recorded. If you want CPD points in the chat, please put your NP number in, and if you've got any questions, we will ask and manage questions afterwards. Thank you very much. Over to you, Lindsay.
Thank you, Renee. And I must put my camera on. So I am not going to start talking today. I'm going to actually hand over to my colleague, Dr. Clare Ellis-Smith, to start, then followed by Sonwabiso, and then myself last. So I'm going to move the slides, Claire, and then hand over to you.
That's brilliant. Thank you. Thank you for the introduction. It's such a pleasure to be invited to speak and join the team in presenting today. So lovely to be here, and thank you. So as Renee said, we are presenting a study that we're conducting on developing and evaluating non-pharmacological symptom self-management, and we're presenting the components of the current evidence and current practices. So our work that we've done so far. Lindsay, next slide, please. As Renee said, the GAP consortium is a global team developing palliative care in low and middle income countries. And this is the team from mixed team in Cape Town and London. And this was taken in Cape Town last year when we were meeting as a consortium and developing our work. So thanks, and next slide. So why palliative care for this population? So we are developing interventions, self-management interventions for people with chronic organ failure, but why palliative care for this population? So we know that people with living with chronic organ failure do live long-term with these conditions, and there are challenges with prognostication. So we don't know when they are approaching the end of life, but they may have palliative care needs right from the beginning of their disease journey, with a gradual deterioration in function right towards the end of life and to death. And the studies show that people will have prolonged gradual deterioration, but points of more rapid decline where they may need greater intervention and greater support. And palliative care is a holistic approach, which is often needs-based. So it identifies when people have palliative care needs and addresses them. And it can benefit people from the point of diagnosis to death and even beyond into family bereavements. So palliative care addresses the physical, psychological, social, and spiritual needs. And we propose that a palliative care approach can benefit all those living with chronic organ failure. So next slide, please. And people with organ failure also live with disability. So we know that some of them will have progressive disability and some of them will have persistent disability. And there's a high proportion of this population living at the end of life who live with disability. They also live with high prevalence of symptoms, including pain, breathlessness, and fatigue, which obviously impact on their disability and their functional performance. Self-management is an approach that skills and empowers and provides knowledge to patients in managing their own conditions, and it particularly supports them to, it's a more of a partnership approach. So they identify their own goals for care, and they are more empowered to manage their symptoms and conditions by providing with them knowledge and skills. And we know that self-management interventions can support patients, but the evidence is largely from high-income countries, and we have limited knowledge about how self-management interventions may work and may best work from patients living in low and middle-income countries. Additionally, we know that access to physiotherapy and occupational therapy support or interventions to provide self-management intervention is rare in low and middle income countries. So this is the basis for why we're doing the study, is really to develop an intervention to support self-management of symptoms for people living with organ failure in South Africa. Next slide, please. So the aim of the study is to develop and evaluate the acceptability and feasibility of pain, breathlessness, and fatigue self-management intervention. And we've chosen a population living with chronic heart, kidney, liver, and lung disease in South Africa. And we've chosen those three symptoms of pain, breathlessness, and fatigue because those have a huge impact on people's ability and function and ability to participate. So we've targeted those particular symptoms and they're common symptoms for people living with heart, kidney, liver, and lung disease. We've detailed here all the objectives of the whole study. So we're planning to develop and evaluate the acceptability and feasibility of the intervention. But in today's presentation, we're only presenting the development components because that's how far along we are in this project. So in this presentation, we're going to present the identification of active components of the self-management intervention. So what are the core and optional components of the intervention? And we're going to talk about the components of developing the components of the intervention delivery, receipts, implementation, and outcomes. So the work that we've done with key stakeholders in developing that intervention. And next slide, please. So our study design is we've used the MRC guidance for developing and evaluating complex interventions, and we've also used underpinning theories of self-efficacy, behavior change, and person-centeredness. And throughout, we've had very strong community engagement, which has informed the study, and we've consulted with community engagement throughout the study, both informing, developing, and conducting the study. The first components of the study is a scoping review, where we have developed and identified the key components of the intervention. So we scoped the literature for studies of self-management interventions to identify what the core components of our intervention may comprise. We've then conducted focus groups with patient practitioners to further understand the context and how the intervention may work, and then developed theory of change work, then conducted theory of change workshops. And in this study, we're going to present the methods and findings of all three components of the study. So I'm now going to hand over to Sonwa, who's going to present the methods and the results of the scoping review. So over to you, Sonwa.
Thank you, Claire. Thank you, Dr. Ellis-Smith. Good afternoon, everyone again, and maybe morning, depending on where you are. I'll be, as Claire mentioned, I'll be talking to the scoping review, which we aimed, the aim was to identify the active components, which Claire spoke to, of the non-pharmacological interventions for symptom self-management in patients living with advanced non-malignant chronic disease. Our first objective was to pinpoint or to identify the active components of the interventions that help manage symptoms like breathlessness, fatigue, and pain in chronic disease. We particularly focused on lung conditions, heart, renal, and liver disease, as Claire has spoken to. That was the first objective. And the second objective was to identify the barriers and facilitators of symptom self-management in these chronic diseases, with our third objective being to explore the contextual factors influencing symptom self-management in specifically low and middle-income countries for patients with advanced non-malignant disease. We defined advanced non-malignant disease as a disease deteriorating despite the best available medical management across all four of the organ categories that we are working with. Thank you, Lindsay. If you can go to the next slide. This is our scoping review method overview. I will speak to the databases search, to the keywords and search strategy, and the inclusion criteria in the coming slides. But important to highlight here is that we used CIFAR, which is the Consolidated Framework for Implementation Research, and PRISMS, which is the Practical Reviews and Self-Management Support taxonomy. We used both to help us with the scoping review, both in terms of extraction and the synthesis. CIFAR more for when we were extracting for the context, facilitators as well as the barriers, and PRISMS for the self-management intervention synthesis. And key to this methods process in terms of collaboration and collaborating with people was the involvement of the medical students from the African Research Society, whom you will get to know their names later. The next slide, please, Lindsay. Thank you. We searched a number of databases to reflect the medical, nursing, and psychology literature, and the search terms for search 1, which is for objectives 1 and 2, the systematic reviews that we looked for from high-income countries as well as low-income countries. Objective 1 is a reminder being the components of the interventions that help manage symptoms for the focus diseases. And objective 2, which is to identify the barriers and facilitators of symptom self-management in these chronic disease. The search terms used were with synonyms as well as with mesh terms, were 1, chronic disease, and combined with self-management as well as symptom. For search 2, which is our third objective, intended to explore the contextual factors influencing symptom self-management in low and middle-income countries for patients with advanced non-malignant disease, we looked specifically for primary studies using the search terms that you are seeing there on the slide. Next slide, please, Lindsay. This is our scoping review inclusion criteria for objective 1 and 2, looking for systematic reviews or looking at systematic reviews, as well as objective 3, the primary studies. Our exclusion criteria eliminated studies which with only pharmacological interventions, and of course the populations that were not our target populations, or with symptoms that were not relevant to what we were looking for, or published outside the time frame that we've stipulated in our protocol. We also excluded studies that had mixed populations without disaggregated findings, and we excluded studies that were on symptoms other than pain, breathlessness, and fatigue. Next slide, please, Lindsay. This is our scoping review data extraction. We extracted these points that are on the slide. There were always 2 people extracting blindly, and we verified our extractions with each other, and a senior member or senior members of the GAP team were consulted where there were disputes. We identified the type of facility where the interventions took place, for instance, such as hospitals, clinics, or community centers, the nature of the interventions, was detailed, focusing on the non-pharmacological strategies for symptom self-management. We documented also who provided the interventions, such as healthcare professionals, caregivers, or patients themselves in some instances. We recorded the total number of each intervention program to understand the time commitment required for these interventions. The framework that we used for this, as introduced in the previous slides, is CIFRA, which is a consolidated framework for implementation research used to systematically assess and evaluate the implementation of evidence-based practice and interventions in healthcare. The framework has a number of domains at the bottom of the slide. For example, domain 1, the innovation domain, the outer setting domain, as well as the inner setting domain. Next slide, please, Lindsay. Our scoping review method, the PRISM's taxonomy. We indicated that PRISM's practical reviews and self-management support. We used this taxonomy to categorize the interventions in our systematic review and in the primary studies. Indirect components, if you're looking at the bottom of the slide, means that any of these could have been delivered instead of being directly delivered to the patients. They could have been delivered to the healthcare professionals or teams or in organizations. So that's the PRISM's taxonomy that we used, and there is a table that follows in later slides that sort of speaks to how what we got using this taxonomy. Next slide, please, Lindsay. This is our scoping review results flowchart according to the PRISMA guidelines, or the preferred reporting items for systematic reviews and meta-analysis. This is from search 1 for objectives 1 and 2, looking for systematic reviews, with 1 being to identify objective 1, if I say this as a reminder, to identify the active components of interventions that help manage the symptoms of breathlessness, pain, and fatigue in the chronic disease that are related to lungs, heart, renal, and liver diseases. And objective 2 being to identify the barriers and facilitators of symptom self-management in these chronic disease. The search produced 86 records initially, and after removing duplicates, screening on abstracts, and reviewing the full articles, we were left with 16 articles to include in our review. Next slide, please, Lindsay. This is our PRISMA flowchart for objective 3, looking at primary studies. The objective here to look at the contextual factors influencing symptom self-management in low and middle income countries for patients with the indicated advanced non-malignant disease. Our initial search produced 3,722 records, and after removing the duplicates and screening on title again and abstracts, we had 72 full articles to review, and 60 of which were excluded, which left us with 12 articles to include in this part of our methods. Next slide, please, Lindsay. Thank you. This is our scoping review, included studies to show where they came from. With the green background is the systematic reviews, and they mainly came from the countries that are listed there. I'm not really going to go through all of them. You can see them. And the primary studies, there were mainly from four countries with the orangey background that you're looking at there: Thailand, China, Turkey, and Iran. Talking or thinking about the settings that the interventions were delivered in, outpatient clinics and various settings in the community, as well as healthcare settings, and home as well, and in hospices. The population was what we looked for in our protocol: chronic heart failure, and end-stage renal disease, for instance. Thank you very much, Lindsay. Next slide. This is our interventions components interpreted using or according to the PRISM's taxonomy. The green represents interventions from systematic reviews, and the orangey color represents interventions from primary studies, or the number of primary studies that looked at those specific things. As a way of an example, A1 is information about the condition and or its management. There are 13 systematic reviews that have interventions on this, whereas there are 3 primary studies from low and middle income countries that speak to the interventions of information about the condition and its management. There were some interventions that we did not find in the primary studies, like A8, if you look on the table, which is access to support when needed. A11, which is training or rehearsal for practical self-management activities, was the one that was most popular from primary studies against set in low and middle income countries. So that's the table that sort of shows in one picture what we found. Next slide, please, Lindsay. This is the intervention delivery. Providers of these interventions were healthcare professionals from diverse backgrounds, as well as, in some instances, researchers provided these interventions. And the time or the duration of the interventions was anything between 6 days to even up to 2 years for some interventions. And the mode of delivery was either in a group or face-to-face individual settings, and some interventions used telephone follow-ups, or as well as home visits as follow-ups. The number of sessions, anything between 1 session to 112 sessions for the interventions, and the duration of the interventions took anything between 15 minutes to about 3 hours as a duration of these interventions. Next slide, please, Lindsay. These are the intervention barriers and as well as facilitators. We found that technology or access or competency around technological tools was a barrier in some instances. There were studies that reported on language as a barrier, and the various barriers that you are also looking at, that you are also seeing there to provide these interventions. The facilitators, as much as the technology in one instance was a barrier, it was also a facilitator in some instances, and also as a facilitator, being knowledgeable about the disease process was one of the things that was highlighted as a facilitator for these interventions. Thank you so much, Lindsay. Next slide. This is our scoping review, the contextual factors. We found that access to pulmonary rehabilitation came up as crucial for those with chronic conditions, but unfortunately it remains limited for many. The presence of family members during these sessions is highly supportive and beneficial, was a finding from the reviews. However, post-intervention follow-ups were often challenging due to the geographical distances where people were set. And currently, there is no policy or advanced symptom self-management, with China being the notable exception in this regard. There are significant reporting gaps that exist, particularly on the outer setting domain of the CIFA framework, and these gaps include aspects like partnerships, policy, financing, and the rest of the aspects that are listed there that you are looking at. Addressing these issues is important for improving the overall effectiveness of accessibility of intervention programs. The review, therefore, the scoping review informed the next parts towards developing our proposed interventions, which Dr. Farrant will speak to. And at this stage, I will hand over to Dr. Farrant.
Thank you very much, Sonwa. So I am going to be presenting on this second objective that you see around addressing the development and refinement of components of the intervention, specifically with respect to implementation, delivery, receipt, and outcomes. And for this, we engaged with a diverse group of stakeholders using mainly focus groups and one theory of change workshop per site. And now this slide shows the stakeholder groups that we considered. Focus groups were separate for each of these stakeholder groups, but for the theory of change workshops, all stakeholder groups were joined together, and community representatives only attended the theory of change workshops. During this presentation, I'm just going to refer to community health workers for simplicity, but the intention is always to include community rehabilitation workers where they are parts of community-based services, and we found that they're not necessarily in all the communities. And as we've mentioned before, community engagement is key to our intention and for this project. And I'd just like to describe how we've worked in this respect thus far. We've engaged successfully with healthcare professionals outside of data collection activities, but the reality of engaging with communities has been different at each site. And so due to prior work of colleagues from our department and other UCT departments, there's a good understanding of community engagement at the Hedeveld Clinic. And I really want to just mention the site facilitators specifically for supporting us and guiding us in this initially, and for their willingness to guide us. And also to thank Bahia and Najjar from Hedeveld, who really helped us set up the meetings that we had, the initial meetings with the communities, with the community in Hedeveld. At the other sites, there's one health forum member at Dunoon CHC, and there is no health forum or health committee at Friedenberg Hospital. So it's been delicate for us to engage, and we are waiting for our research assistants to be appointed, which will happen next month, and then we'll be able to, we hope, engage more in this respect. This is a bit of an overview of our methods in terms of data collection. Our sampling was purposive for the stakeholder group, focus group discussions, and for the theory of change workshops. For the focus group topic guides, we looked particularly at all stakeholder views and preferences for care delivery and care receipt. We discussed what they currently do, whether it's what patients do at home on their own, what the family members do, but we also asked professionals what they teach and what community health workers teach. And I put in yellow what we have defined as self-care or self-management in all of our engagement with all the stakeholders, so that we try to be consistent with our explanation. But then we used the focus group data to inform our theory of change program and approach and questions alongside the scoping review findings that Sonwa has presented. So analysis of all the qualitative data has started, but as the word cloud shows, we are in the early stages. We are coding still, and we're still awaiting some of our transcripts and translations. So what I'm going to present today is preliminary and based on our thoughts of participation in the research activities and our initial coding. What we have, we're using the framework method for analysis, and we have decided to use the 4 themes from our objective being implementation, delivery, receipt, and outcomes, and then did inductively coding sub-themes to those themes. Data collection to date is recorded here. We recorded by site and by participant stakeholder groups. So data collection is complete at the Hedeveld Clinic and Friedenberg Hospital and ongoing at Dunoon. We've primarily had focus groups, but also had to include in-depth interviews, one-on-one in-depth interviews with patients and caregivers and with 2 healthcare professionals. Patients and family members seem to find the focus group attendance or access to the clinic has been a challenge. So particularly at noon, we find that it's been easier to engage one-on-one interviews. This is allowed in our protocol. And then I've also put in here the Theory of Change workshop. So we've had 2, as I said, and we still await the 3rd in August. So I'm going to talk through our preliminary findings for each of those themes that I mentioned. And regarding implementation, so there are a number of aspects to consider. And here on the slide, I'm looking at the context perhaps and the content of the intervention. And it does appear that the content of the intervention needs to provide information, but it also needs to provide a practical engagement with skills being taught and practiced and supported by the patient and the family member. With this patient in the focus group in Vredenburg describing how when she had received teaching from a nurse on how to exercise and what would be considered exercise, she found that a meaningful engagement and very helpful. And we know that we need to consider the context. So each site is a different context and culture. We need to consider the historical legacy, perhaps, of the lack of self-efficacy. And it's been emphasized again and again that the psychological needs of the patients, but also the community health workers, are important. We need to consider that. And so that will be considered in terms of our engagement with this patient, saying, if you must go to the doctor, okay, the prescription for pain, but what about the psychological side? So in terms of delivery, it's also clear that we need to have a unified message. So what the healthcare professionals say must be the same as what the community health workers are saying. So what they hear at the hospital or in the clinic and then receive care in the home must match, and we must involve the families. To be able to then provide appropriate content and skills training to each individual, we actually need to know what the person is doing. So we need to know, are they able to sweep, for instance? Do they sweep, or are they not that able? Are they able to do other activities which are more sedentary but allow them to engage with activities and potential exercise, for instance? When we do that, we are finding out about them and engaging and building relationship, but we're able to provide short snippets of information and scaffold the information that we have onto each step. So building iteratively, and it needs to be, as I said, interactive. And trust is very, very important. And this is something that we will have to engage with during the implementation. And for patients and family members to be able to be free to share their experiences and receive input. So I think I've covered a little bit of receipt in the previous slide in my discussion, but again, trust will impact receipt, but we need to consider what is meaningful and purposeful for patients, and we need to consider this aspect of building hope and how we do that appropriately. So as I've said before, short, clear messages, considering the patient's daily rhythms. Stories have come up again and again. How can we engage with stories, not just telling stories, but allowing patients and family members to tell their stories? So those listening skills, communication skills. It's likely that there will be individual intervention, but also group setting intervention. And we're going to need to engage with emotional coping support for a wide variety of stakeholders. And we've tried to stay away from end-of-life aspects. We've tried very much to focus on the symptom self-management when patients are not necessarily at the end of life, but repeatedly patients, family members, and community health workers really wanted us to go there and address and talk about this. So patients these groups of stakeholders are looking for information and support in this area. So we are likely going to have to engage with some training and intervention support in that area. In terms of outcomes, we're still discussing this quite a lot in our team, but outcomes are going to be diverse, and I've got here mainly patient and family member outcomes. In terms of clinical outcomes, we will want to look at readmissions to hospital, emergency department visits, and then symptoms. So the individual symptoms of pain, shortness of breath, and fatigue. And we will need to consider, do the patients and family members and professionals and community health workers feel that the intervention it provides them with sufficient information and resource. And then from a psychosocial, spiritual point of view, looking at, has there been some degree of empowerment, coping? Is there less panic and anxiety in emergency situations or stress situations? So these are how we measure these. We are still working through, but this is what has been suggested by the stakeholders. So what we have done following the focus groups and the Theory of Change workshop is drafted what is our a first draft, and what you see here is a first draft Theory of Change map for symptom self-management. And so this map has been drawn up by the research team based on the data, but the intention is for iterative review and input from stakeholders in the community so that it can be appropriate for intervention. We have one further Theory of Change workshop at the noon, so we will also be able to actively look at aspects and update them. But essentially what it's saying is that we are intending to develop a toolkit, have that intervention with an appropriate manual to apply the toolkit, and then train professionals, community health workers, in order for them to deliver the intervention, provide the care, and then for us to measure outcomes. So it does appear that there is relevance for symptom self-management in chronic disease, relevance and acceptability, and the need for this in our settings. And it is likely, we had thought initially that delivery would be driven by healthcare professionals, but it seems that it's probably more likely to be driven by community health workers who appear willing and wanting to do this, but will need training and support and mentoring. So our next steps are intervention development, intervention toolkit development, and then a non-randomized feasibility study to assess the acceptability and feasibility of the intervention. And so just some acknowledgements. Sonwa mentioned the students who helped us in the scoping review, so Alexandra Jayon and Frank Teaser, who were involved with our inclusion, exclusion, data extraction, and very grateful to their support. It was a great engagement. And then the partnership logos at the bottom are the GAP consortium partnerships for the other work streams who work in Zimbabwe and Uganda. And then, of course, King's College in London. So this is our acknowledgement to the funder. And we also have a few slides of references for those who would like. So thank you. I'm going to leave it perhaps here.
Thank you very much, Lindsay and team. Really a brilliant presentation, and you start to realize actually how complex any engagement with a patient is. So thank you, well done. I'm going to open the floor for any questions. Lindsay, I will start the conversation, and I'm going to ask you why preliminary thinking that we've got to concentrate on using community healthcare workers and community rehab workers to implement the interventions.
Thanks, Renee. So I think really what has come out, particularly with our engagement with the community health workers, they really are engaging with patients in homes. They're not necessarily getting referrals for all these groups of patients, but when they do, they are looking for support in how to support the patients. And what we were presenting was very appealing to them, it appeared to us. And they were very, very eager to get involved. So from that perspective, but also the sense that the healthcare professionals are just so busy and don't have the time necessarily to spend. Perhaps that's an assumption on our part, but we don't want to leave them out of the intervention because the messages need to be the same. But I think the practical, actually supporting the patient in the reality of their home is probably best delivered by the community health worker. I don't know if anyone else wants to add to that.
Okay, there's more questions. Steve.
So thanks, Lindsay and Sona and Claire. Excellent presentation. I've been fascinated by the impact of music as a non-pharmacological intervention, specifically singing for patients with chronic lung disease. And I'm aware of a number of studies, some quantitative, some randomized control studies, but a lot of them qualitative, that back that up. And there are even some systematic reviews on the role of singing. And then there was a very interesting study in the Eastern Cape with community health workers who used singing in their work. And it was run from somewhere in the UK. I'll have to look it up. But the impact was quite significant. It was through the public mental health research group and Tandy Davies, I think. Fascinating. So that was a year-long study, and I spoke to the researcher who actually did the data collection and the singing with the community health workers and their patients. I just find the whole thing fascinating, what the randomized control trial showed with the choir singing. And so that's a group thing, not individual, is that patients benefited more than just a group activity. Like if they got together and sang, as opposed to they got together and whatever, talked or did something else, the singing had a more positive impact. So what explains that? I don't know, but obviously you're using your lungs and you're inspiring, expiring more than you normally do, but it's enhanced by the emotional thing of doing it together as a group. All those studies kind of nosedived over COVID because you can't. But there were some from before and some since then. Thanks.
Thank you.
Yeah, super. I think, Claire, I don't know if you want to say anything to that.
I think it's a really, really interesting. And I think you can absolutely see how it could be really beneficial intervention and see some of the mechanisms behind it. And I just wonder, because I didn't do the screening, did we come across those studies in our review, and were they included in the review?
I was just thinking, I don't recall. Sonwa, do you recall? I do recall in our group discussions people talking about singing and music and the benefit of music. But Sonwa, I don't recall actually.
It's a really interesting intervention or method, but I also don't recall from the studies themselves. No, I don't. Yeah.
I think really helpful, and I think be worth looking at the inclusion criteria and just going back to the studies as well, because it's fascinating, isn't it? And really kind of empowering for patients too. Thank you.
Yeah.
CHIME. It's called the CHIME project, CHIME. I just found it.
Thank you.
Andrea, your hand is up.
Yeah, I was wondering, so obviously CHWs are going to the house, which is very useful, but the people who are with patients the most are family members and caregivers. So I'm wondering if the sort of training you are envisioning for CHWs could also be given to families, or if you think that it would need to be sort of separate type training and support programs.
Yeah, thanks, Andrea. So I think what we're aiming at is training healthcare professionals and then separately training healthcare community health workers and mentoring them to provide the training support to the family alongside what they get from the healthcare professionals. But we envisage a toolkit which provides information and options for managing situations for the patients and also for the family members. So we're envisaging very tailored options for family members, as you say, because they are the ones that are usually there and really do need support. And the scoping review and our findings from the focus group and the theory of change definitely say we have to include the family members. Caregivers, I guess, family caregivers, if they're family caregivers, if you're defining them like that, if they're caregivers that are coming in, they would need to be included. If there are such caregivers, they would need to be included in the training too. Yeah. So everyone involved would need to be on the same page with what do I do when I'm short of breath and I'm really panicky? Instead of first phoning the ambulance, how do I manage my anxiety? How do I slow my breathing down? What do I do with my prescribed inhalers? And then what can I use? What are the techniques for controlling the breathlessness and anxiety? How do family members plan? How do they act in crisis? Such things.
Thank you very much. Any other questions? Perhaps, Lindsay, my final question is how do you think, because from the scoping review and some of the barriers and the facilitators, and because we are working with a diverse population, how do you envisage actually measuring the trust factor?
A good question. I think I would value input on that, but I would imagine that the qualitative interviews that we plan to have post-intervention will be wanting to explore that with patients, family members, community health workers, and professionals. There may be tools that we can look at from a quantitative point of view that I may not be aware of. We are looking at process evaluation and also looking at satisfaction tools, so the satisfaction of experiencing care. That's part of an answer, perhaps. I don't know if anyone else wants to add.
Thank you. I see Baya's hand is up.
I've got a question in relation to, I think, first of all, thank you so much for the presentation. It's a fantastic presentation. I would like to know, in the light of all the very many other things that community healthcare workers are doing or responsible for, how do you envision, because what I'm seeing or what I'm understanding is it's going to be your intervention is going to be some kind of a trainer of trainers where the community healthcare workers are going to be trained, and then that information is going to be taken to the household. So my question is then, with the other responsibilities that they do have, how do you envision this information to be transferred to the household? Is it going to be like a case-by-case basis, or taking into account, I'm not sure the time or how long this kind of information needs to be taken over. I'm just wondering about the load on the community healthcare workers. And I'm by no means saying this is not necessary. It's definitely necessary. But what do you envision around all of the other things that they have responsibilities for as well? How do you imagine it fitting all in?
Yeah, thanks. But yeah, I think that's important. And I don't know that I have the full answer. However, what we intend is to have bouts of sort of sessions of training at an appropriate time for as agreed by the community health worker manager in times that are suitable to them, and short bouts of training, not necessarily long sessions, and doing that repeatedly, providing them with a manual, with practical toolkits in terms of information leaflets that they can hand out to patients, but also things that they might be able to use, like a poem they could sing, or maybe there's a song that would be useful to sing, and so on, so that they have a toolkit that they keep, but they have resources to share. And we wouldn't be envisaging them doing additional work, but just doing the work that they do anyway. So perhaps it might, when we are recruiting patients for the feasibility trial, we would be wanting them to see those particular patients. So perhaps there would be an additional patient referral, but it's actually what they're asking for. And we see it as just supporting their skill sets for any patient that they see, whether it's someone that's enrolled in our trial or not. That's roughly how we see it. So hoping to strengthen the system by providing these kinds of resources to the teams on the ground.
Thank you so much.
Lindsay, and I would just add that that's why we're doing huge amounts of stakeholder work with them, to understand how it would work in their normal practice and not increase burden. So I think part of it is working with them to develop the intervention, but really give them tools and resources so that they can, they're more empowered. And the intention hopefully is that they're more empowered rather than more burdened. But the feasibility study will explore that certainly much more in terms of the impact on them. So I think that's a really important question that we will be considering.
Yeah, I think it will be important output of the feasibility study.
Okay. Thank you. Yes, Sonwa.
Renee, if I may, there is a question from Edwina in the comments section. I don't know if I missed anything. Did you address that one? She's asking how many LMIC countries were in the review, which interventions were most common in these countries, and she wasn't clear on that. So from the primary studies, they came from mainly the 12 primary studies came from Thailand, China, Turkey, and Iran, and those are the countries that where they came from, and out of the 12 studies from these specific countries, 10 studies discussed training or rehearsals for practical self-management activities, the daily things that people need to do. So I'm not sure if I've answered your question, Edwina.
Yeah, and I think the large number of countries included in the systematic reviews that we reviewed were high-income countries, but China, Brazil, I'm just looking at the list, India, Turkey were low and middle income. So a smaller number than high-income countries in the systematic reviews.
And then I think the next slide is also quite interesting, because the low and middle income countries looked particularly at certain interventions. So you can see the AE11 intervention was much more common in low and middle income countries as well, which I think was training, wasn't it, Sonwa?
Training and exactly, training and rehearsal and practical symptom self-management activities. And A1 is information.
Thank you. And thank you, Sonwa, for picking up that. Thank you, Edwina. It's a very good question. And even in those countries, they're not really low income countries that you've mentioned. And it's going to be very important to actually look at this and how applicable is it in really low income countries, where self-management is such an important aspect of care. Any further questions? I also just want to comment on the interdisciplinarity of this project, which is probably one of the very strong aspects of this project, where we are using occupational therapy, physiotherapy, family medicine, palliative care, anthropology. All these aspects are actually to try and determine what is going to be the best aspect of an intervention and how we're actually going to apply it, and how important this interdisciplinarity is when we are doing complex interventions. So thank you very much. And I think we can give a hand to Clare, Lindsay, and Sonwa. And I hope to, within the next 2 years, we'll be able to give you a full lecture on the outcomes and how they actually were met in our communities. Thank you very much. And thank you again for primary healthcare. I haven't said enough for primary healthcare, who's really assisted us at all the sites. Thank you very, very much for that. Thank you. And I also just want to draw your attention to on the 18th of July, there is also another gap lecture on ethnography and how to becoming an ethnographer. I have posted the link in the chat. Please, if you are interested in more of this kind of research, please book your ticket and attend this lecture. Thank you very much, everybody. And I think we can say goodbye.
Thanks, guys. Bye.
Thank you. Bye-bye.
Thank you. Bye.